And here's 0.1, 0.2, and 0.3. Yes. If we look at, there's no covariate standardized mean difference below 0.1 after matching, so the study is a good study. And how about this one? No, right? Because now we see a lot of points that is being mismatched. That indicates even after covariate, propensities for matching, or after this is the stratification table. So we still have a lot of covariates that do not pass the and these variables that fail covariate balance means, right, they are still not, you cannot consider the treatment randomized with respect to those covariates. And you either adjusted them in your downstream analysis, or you have to do something for sensitivity analysis to ensure that you do not have residual confounding bias from those covariates that miss the diagnosis. The third diagnostic that the community implemented is called expected absolute systematic error. And this is estimated using a set of negative control outcomes. So a negative control outcome is an outcome that we believe the exposure has no causal effect at all. For example, think of ingrown nails. If you're studying the effect of antihypertensive medications, right, blood pressure lowering drugs, that drug should have no effect on outcome called ingrown nails. So in this case, ingrown nail is a negative control outcome. And in the community, for every study, we select a set of somewhere between 50 to 100 negative control outcomes to assess the residual confounding in the study by using those negative control outcomes. It's very worthy to explain, and I hope this figure will better illustrate the idea. So this figure here at the x-axis is the effect size. In this case, the estimate is the relative risk, and the y-axis is the standard error. And the two diagonal line indicates where the p-value equals to 0.05 would be. So if there's a negative control outcome that is in this white region, that means we do not detect a significant causal effect for the negative control outcome, which is what we expect. But if we see a lot of the dots in the two orange regions, then those are false negative signals from the database. And if a lot of our negative control outcomes were found to be falsely positive, then that would indicate residual confounding bias instead. That is how we use this figure how you read this figure to understand the residual confounding study. And there's a formula for taking all the negative control outcomes, their effect size and confidence interval to compute what we call E-score, which is a scalar value that allows us to assess the residual. So and so here's a plot we did. So there's more how we use the negative control outcomes, not just as a diagnostic tool, but we can actually use it for calibration to calibrate the hazard ratio on the outcome that's of interest to the study. That I didn't have the details here, but that is another way that we can use the negative outcomes to further calibrate our
analysis. So is that meaning sort of adjusting the effectors for the bias?
Yeah. And I also have the contrast of so here before calibration, you see in this that study, we have a lot of residual confounding because a lot of the negative outcomes are found to be significant. And after calibration, then all of the negative controls are not significant. Versus if a good study, there's a little residual confounding, then even before calibration, the plot is the phase. And this is the last final diagnostics called the minimum detectable relative risk. This is essentially a power calculation for observational studies. In randomized controlled trials, we're going to calculate power to determine how many patients we need to recruit for a study. But for observational databases, right, the sample size is fixed. We don't have more patients even if we want. So we reformulate this power analysis question as given the available data, what effect size would the analysis be able to detect based on the samples? And we also report that diagnostics across all databases and all hypotheses that we tested. So this MBRR, this case is all less than 1.75. That means the study is able to detect 75% increased risk if present across this database versus a bad MBR of like 6 or 20 or 30 or even hundreds that we have seen for some very rare outcomes. That means, right, the effect size has to be 6 times more elevated compared to your control in order for it to be detectable. So to quickly reorient where we are. So what I just went over with you is the large scale propensity score model and also the set of diagnostics that we implement for doing population level evaluations, comparing treatments in terms of their effectiveness or safety across databases. Within one database, then if the study has all diagnostics over database, then the results will be applied to the study lead and will be further used in meta-analysis to form a meta-analyzed treatment effect point estimate and confidence. So those are kind of the exactly how things work. What are the methods we have implemented in the community? And now I want to take you to go through a case study that we recently completed within the Odyssey network, and that is the semaglutide and IOS. To give you a little bit of background, so earlier last year in July, there was a study came out in JAMA Ophthalmology that found very commonly used drug semaglutide for treating diabetes can cause an elevated risk of stroke of the optic nerve, and this with an alarming hazard ratio of 4.28. So this paper was picked up by a lot of social media and it caused a lot of concerns both with providers and also patients because semaglutide is a very widely used drug among patients with diabetes. But after we reviewed this original study, we found a lot of limitations in how they, so this is an observational study, and we found a lot of limitations in their study design. So, and as a community, we decided to study the same question across the data, our data partners and see, to basically to answer the risk, is there an elevated risk of NAIL among patients who are taking semaglutide versus other diabetes medications? So I've just figured to illustrate the study design, target drug, the drug of interest is semaglutide, and these are other drugs for treating diabetes. The outcome of interest is NAILN, which is this rare adverse event in the eye, and we have 2 definitions of it. So that means just whether we require only 1 diagnosis code for this outcome or we require 2 diagnoses. As you know that EHR data, sometimes those diagnosis code isn't very accurate. Right? We only see it once, the patient may or may not have that disease. And so we adopt a new user cohort design, meaning we limit the cohort entry event to the initial prescription of either the target drug or the comparator drug. And the patient needs to have at least 1 year of prior observation before treatment initiation so that we can capture confounding in that pre-treatment time. And there's some other inclusion criteria for this cohort. So the analysis plan is to, for this new user cohort design, we use large propensity score to adjust to estimate propensity scores and adjust for confounding. And then within matched pairs, we run hazard ratio, marginal cost proportional hazards model to estimate the causal effect. And for meta-analysis, we use a Bayesian random forest model. In terms of the data sources, this includes 14 different databases, 8 EHRs, and 6 claims. So the map shows where the academic medical centers, academic medical centers participated in this study that include both West, East, West Coast, and figure in the middle. Perfect geographical location or actual maps. And there's other claims like Medicare, Medicaid, private insurance, CCAE, and some of our industry partners. They also purchase the data. So in total, the study includes 37 million type 2 diabetes patients, which is almost the same magnitude of the number of type 2 diabetes patients you would expect in the US population. Although we're not claiming that we do have this high coverage because some patients could be represented in multiple databases. So we did not control for any of those duplicates because we're not re-identifying patients. Then as part of the results, we first show this is kind of association showing the incidence and incidence rates of NAION across the different exposure groups. Semaglutide is the target, but we show the incidence across other groups. So from just eyeballing, there are groups that have more incidence actually compared to semaglutide and more NAION cases. But this is just a subset. For this causal analysis, here's the plot. So on the left, we show the results for the sensitive NAION, and on the right is for the specific NAION. And let me orient you to the right side of this figure. So each subplot is one comparison or one hypothesis we test. So for example, this one semaglutide with dulaglutide, and the rest are with different comparator drugs. And the meta-analysis estimate is shown in yellow, and the individual databases estimate was shown in green. And what you see here is that we don't have all the databases here because, as I mentioned, if a database did not pass all the diagnostic, then we do not use their results for meta-analysis. Only the databases that pass all the diagnostic end up showing. So that's why for some of the comparisons, you may see more databases than others. But overall, if you're interested in the clinical finding, then first of all, we didn't find anything that's with a hazard ratio of 4.2 as reported in the original study. And there's one sort of just above the significant threshold is the semaglutide with this other drug. And the hazard ratio is 2.27 with the lower 95% confidence interval at 1.6. So the overall message from this study is that yes, there could be a slight increased risk of NAION among semaglutide users compared to this other drug, but the ultimate benefit versus risk assessment is up to. But overall, we do not think this slightly elevated risk outweigh the very strong benefit of this drug in patients with diabetes, and especially with patients with cardiovascular comorbidities, because there's a much stronger signal of this drug being protective against some cardiovascular disease in patients with diabetes. So don't quote me on the clinical significance of that, but that's I believe the main takeaway. Although we spend a lot of effort in the diagnostics, but those don't often end up in the main manuscript that you publish in a clinical journal. But anyway, we still report that in the supplementary materials, and this is a snapshot of some of those diagnostics, and you see what are the value of that diagnostic and whether the database has failed that diagnostic. If for people who are interested. And this is, yeah, I don't have a slide for that, but all the study packages and codes are available on the GitHub page. Yeah, so a quick recap of the timeline. How long really did us took us to run the study across 14 databases? It is only 6 months. I consider that really fast for a study at this scale. And this is about how long each step took us to do. And what you would find is that actually getting through peer review took the most amount of time than study execution, study design execution, and paper writing. So I think one last final message about real-world evidence generation is that I think there's a huge potential observational databases. It is possible to generate evidence at scale reliably in a relatively short time frame. However, disseminating messages from observational studies, increasing the validity or reliability of real-world evidence in the general medical community, so that study results like this will eventually impact clinical guidelines and patient care, is where I think it's still lacking efforts, and that's one of the and some researchers. So very quickly go some other ongoing projects that in my lab that I'm doing with my students. So what I presented you is a pipeline for generating evidence for population level. Right? We're looking at a large patient population and say, well, is the drug safe or effective? However, there's an ongoing need for understanding drug effect in the subpopulations, right? Towards the degree at the patient level. So here, this is a illustration showing that the x-axis, this dotted line represent, right? This is a population level treatment effect on average, how a drug works in the population. But if you look at individuals, some patients may benefit more from the drug, some benefit less, or even harmed by the drug. So how can we design, how can we estimate treatment effect at subpopulation level? I can work with my PhD student to design algorithm that can take in large high-dimensional covariates and estimate the treatment effect at the individual or subpopulation. So this is where looking at survival outcomes. There's other methods out there for binary continuous outcome, but we're adapting this to survival analysis. I'm also working on integrating other data sources with EHR. Even though we have a very good capture, the EHR has a very good capture of a patient's the information that are recorded in a clinical encounter. There's still variables that are not recorded, like social determinants of health. So I have a student who works on integrating, so geocoding patients' records integrated with other geospatial data sets like American Community Survey and other survey data to capture social determinants of health. So that we can use for temporal analysis of patients, looking at the geographical distribution, and also through statistical modeling, understanding the impact of SDOH on treatment assignment or outcomes. So one of the use case that we have looked into is opioid use disorder and opioid overdose. We look at across PJC healthcare, where our OUD and opioid overdose patients come from, and what is the aggregate deprivation index of that census tract that our patients. And I have some ongoing collaborations with others at WashU Medicine, actually Dr. Inkal and Cassie. We're collaborating on characterizing the colorectal cancer patients within BJC, understand their age of diagnosis, symptoms that lead to diagnosis. I've seen some familiar faces here from his team that we have met for this project together. And also in ophthalmology, Dr. Rao is interested in drug safety studies, similar to the kind of using the OSCE pipeline to answer questions, but we're also looking into other more kind of new innovative domains, integrate imaging data and extract imaging information from the eye images to further enhance our data sets. Okay, with that, I would like to thank my colleagues at WashU who spend a lot of time, effort to transform our EHR data so that I can use it for various analysis, and also my students in my lab and the OPS community for years of dedication to building this infrastructure. Real. All right, I'll stop here and I'm happy to take questions.